I'm Dr. Ken Landau. This is Well Now Doctor. Thank you for joining us. We're going to talk about osteoporosis and how we make the diagnosis. Now, it's important to realize osteoporosis is a disease, a disorder that lots of people suffer from. Most people who have osteoporosis don't even know they have osteoporosis because osteoporosis is asymptomatic. You have no symptoms if you have osteoporosis. It's just a marker. It's kind of like, do you have any symptoms of elevated cholesterol? No, not until you have a heart attack. Do you have any symptoms of elevated blood pressure, the standard elevated blood pressure that people have that's just mildly elevated? No, no symptoms till you have a heart attack. But do all people who have elevated blood pressure or have elevated cholesterol go on to develop heart disease? No, of course not. Do all people who are overweight develop diabetes? No, of course not. And as a corollary, not all people who have osteoporosis develop any kind of problem. In fact, if we make the diagnosis and we begin treatment with some kind of expensive drug, are we going to get any benefit? Well, it's kind of hard to say because the overwhelming majority of people are not going to go on and develop symptomatic fracture. So the overwhelming majority of people may well be treated without any good cause. Well, we know osteoporosis is extraordinarily common. If we look in the United States at the present time, there are at least 10 million people who have been diagnosed with osteoporosis. It's 8 million women, 2 million men. We know that there's a condition that is called osteopenia. Osteopenia exists when a person doesn't have normal bone mineral density, but on the other hand, they're not as severe as having osteoporosis. They're sort of in the in-between ground. Now the question is, what do we know about people with osteopenia? Are they going to progress to osteoporosis? They may or may not. We don't know. But if we look at all of the people who have what are called osteoporotic fractures, we find that probably more than half of them don't have osteoporosis. They just have a little bit of reduced bone density. But that's another issue. What is reduced bone density? We make the diagnosis of either osteopenia or osteoporosis on the basis of what a normal 20 to 40-year-old individual's bones look like. Well, if we said that your heart at age 80 wasn't as good as a 20-year-old heart, we would expect that makes sense. On the other hand, when we talk about bones, we say, oh my goodness, if your bone isn't as good as a 20-year-old bone, then you have a condition that needs to be treated. Same token, we would say if your lungs at age 80 don't function as well as they did at age 20, oh my goodness, you have a lung disease. We've got to get you on some kind of medicine. Ridiculous. If you're age 80 and your liver doesn't function as well as it did when you were 20, your brain doesn't function as well as it did when you were 20, does that mean you need some kind of therapy? Well, at least in the case of osteoporosis, the answer is, well, yeah, you need therapy because we have therapy. And that may well be the most common reason for people getting the therapy, simply because we have some kind of a drug, not necessarily because they need the drug. Now, if we're going to make the diagnosis, theoretically, we have to have some kind of numbers. We have to have something to compare it to. So what we do is we do some kind of bone density testing. Now, the hip is the preferred site. But actually, in perimenopausal women, in women between the ages of, say, 45, 50, 55, or thereabout, well, it seems that the area that's implicated first is actually the lumbar spine. So when we're doing our tests, we ought to go and measure the lumbar spine. We can measure the hip too, the femur, but what we really need to do is we need to consider what's happening in the spine. That sort of gives us a guidance. Now, what kind of tests do we have that can measure the bone density? Lots of tests, and there's substantial difference between the tests, and they don't measure exactly the same thing. So we have the standard test, it's called the DEXA, that stands for Dual Energy X-ray Absorptometry, DEXA, or we have the Single Energy X-ray Absorptometry test that can be done, not nearly as popular. We have the quantitative CAT scan, is something called extreme CAT scan. We have ultrasound examinations, and all of these are done, and the doctor looks at you and says, your bone density is -3. You need therapy. Actually, all of these tests have very poor predictive factors. They don't predict who is going to develop osteoporosis, or at least who's going to go on to develop the fracture. Now, the DEXA scans supposedly are highly accurate. It's the standard. You can use it at any skeletal site. Usually it's used at either the hip or the spine. Could be done at the heel or the two bones in the forearm, the radius, the ulna. Could be done even in the fingers. We have portable machines. Unfortunately, the DEXA scan only gives us a two-dimensional view of the bone. We really want a three-dimensional view, but we only get a two-dimensional view. And as a matter of fact, there are other problems. If you're short, you're going to have a lower bone density than if you happen to be tall, even if your bone density really appears to be exactly the same. And we also know as you get older, you tend to get some bone spurs on your spine. And they get in the way of the readings and can give you a false abnormality, give you a false reading, give you a false elevation of the reading because there's more calcium down there. And the DEXA is going to estimate the area of mineralized bone. What it's going to do is it's going to take the mineral content and divide it by the area. And unfortunately, that doesn't correct for the bone size. Well, additionally, we have different DEXA machines, and they put out different kind of energy and give us different kind of results. So the standards are different, just like in different laboratories. The normal blood sugar in this laboratory might be one thing and different in another laboratory, or the white count or the red count. And the same thing with the DEXA. And we have to realize that all of the results are compared to otherwise normal 20 to 40-year-old women. Now that's very important because remember we said that your maximum bone density is going to occur sometime prior to your being age 35. So it's very important what you do as a kid. It's very important what you do as a teenager. It's very important what you do as a young adult. Your diet. It's very important as far as your exercise is concerned. But more important than anything, overriding all of the issues is your genetic inheritance. Because if you don't inherit a gene that's going to allow you to develop thick enough bones, it doesn't make any difference what you do. You're going to have relatively thin bones. And another thing, all of the standard readings we have are called T-scores. T-scores, the letter T. Well, we also have a Z-score. And a Z-score, instead of comparing you to a 20 or a 40-year-old individual, typically a woman, what the Z-score does is compare you to somebody your own age. And it's kind of confusing because you can have a Z-score that's otherwise relatively normal, let's say it's -1 standard deviation, but your T-score, which is what everybody gets excited about, the T-score could be, say, 3 standard deviations below normal. Now, what do we measure to make the diagnosis of osteoporosis? You got a lot of bones, but the bones that we measure that are used to make the diagnosis are either the lumbar spine, the femoral neck, or the total hip. Any of these areas that has a bone mineral density or a T-score that's more than 2.5 standard deviations below normal, that gives you the diagnosis of osteoporosis. Okay? Well, we also could do a quantitative CAT scan. Principally, it looks at the L spine, but it could look at the hip more recently, and it's also been used to look at the forearm and look at the tibia, the big bone in the leg. It's a three-dimensional test, so that actually provides an estimation of the density of the bone. And that gives us a better reading or better analysis. Unfortunately, the test is much more expensive. It exposes you to a bunch of X-ray, and it's less reproducible than the DEXA scan. And now we've gone a step further, and we have something called the extreme CAT scan. And the extreme CAT scan can tell us, remember we were talking about, in an earlier show, we were talking about the spongy component of the bone and how you have spicules that are interconnected, and they provide a lot of strength. It's not just the struts on the bone, but it's the interconnections that go in between the outside of the bone. And those trabeculi can be determined, and it can be determined whether they're connected or whether they're not connected by some of these CAT scan techniques. It's important to realize that if you lose the connectivity, if it's broken, it's kind of like when you have a nerve injury. If you cut a nerve, well, unfortunately, you can't get the nerve to grow back and touch the other side of the nerve. And when you break the little spicules, when you break the little trabeculi, then it doesn't matter how much calcium you put here and how much calcium you put here. If the two aren't connected, you're not going to get a strong bone. Now, additionally, we could do an ultrasound examination. In the ultrasound examination, we use the calculated attenuation of the beam as it passes through the bone, or the speed that it traverses through the bone. It's less consistent, and it may well measure things other than what we expect. So we don't exactly know what to do with the ultrasound examination. It's popular, but how meaningful, just don't really know the answer to that. Prior to the 1980s, we made the diagnosis simply on, hey, you have a fracture, you're old, you probably have osteoporosis. As we get a little more sophisticated, well, then we started doing the DEXA tests, and as we get into the 2000s, now we have risk prediction tests. We can measure the fracture burden. We can determine who's most likely to get osteoporosis or osteoporotic fractures. And remember, we don't really care about the osteoporosis, we care about the fractures. And remember, the fractures have to do with falls. So no matter what kind of tests we do, we can't determine whether you're going to suffer the fracture. But it's also very important to realize that on all of our tests, the people who would appear to be most at risk, the people who would have the osteoporosis, they're not the ones that necessarily are developing the fractures. Remember, we said that at least half of the people, considerably more than half of the people who develop osteoporotic fractures don't have osteoporosis. Well, as we get a little more sophisticated, now we have something known as the FRAX, F-R-A-X tool. You can look it up on the internet, Google F-R-A-X. It's a web-based technique. It was developed in 2007, 2008 at the University of Sheffield in England, and it was developed under the aegis of the World Health Organization Collaborating Center for Metabolic Bone Disease at the University of Sheffield. And what it does is it identifies people who have a risk over a level, a 10-year risk of developing problems. It's been used tens of millions of times, but unfortunately, as with everything else, there's a lot of controversy about this kind of a test. And the controversy has to do with how the study was done, what kind of information they used. And unfortunately, with this particular technique, was heavily funded, the development was heavily funded by the drug industry, obviously pushing the drugs. They say, now we're doing it just for good measure. Maybe they were, maybe they're altruistic, but you have to be a little suspicious. And the people involved were people who had some sort of bias towards screening. Doctors, professional organizations where screening was supported, other kind of groups where screening was supported. So there's a lot of controversy. And there are a lot of reasons why actually bone density in postmenopausal women might not predict the risk of osteoporosis of the hip. First of all, you have to realize that the bone density that is used to direct treatment supposedly is going to give us those people who are at most risk. And then we're going to treat them with our anti-resorptive drugs. The drugs that are used right now, the overwhelming majority of drugs, certainly the commonly used drugs, are drugs that prevent resorption of the bone. Once you have the bone, remember we said that you lose the bone mass. Well, that's what we call resorption. Well, if we look at a 10-year chance of having a hip fracture in a 50-year-old woman, even if she's at twofold increased risk compared to normal, her risk is only about 1.4%. And if we could reduce the risk by 50%, we could reduce her risk of having a bone fracture of the hip, down to 0.7%. That's a 50% reduction. A 50% reduction going from 1.4% down to 0.7%. Or we could say that instead of a 50% reduction, we could say it's a 0.7% reduction with therapy. That doesn't sound so great. And there's no evidence, at least at the present time, that, at least in perimenopausal women, that we can get any benefit, any substantial benefit, by using our treatments, by using the drugs that we have available, the drugs that tend to be somewhat more expensive. So there's an issue. Another issue is the fracture protection and the bone mass are very poorly related, poorly correlated. Yes, indeed, the anti-resorptive drugs tend to restore some lost bone volume. That's the way they're marketed. But the question is, does that increase in the bone density decrease the likelihood that you're going to suffer an osteoporotic fracture? And the evidence is actually kind of sparse. That's interesting. The evidence is sparse that if we restore some bone mineral density, we're going to reduce the likelihood of a fracture. Because remember, the reason you have a fracture is number one, because of the genes, and number two, because of the fall. Well, what's bone mineral density have to do with that, especially when we're talking about relatively small numbers, 1 or 2 or 3%, typically. And then we have recent multi-center trials, prevention trials, looking at the drugs like Fosamax and Actonel, and another one that's called a SERM, it's raloxifene. And it says that we can reduce the likelihood of fracture by somewhere between 40 and 50%, and we can actually gain bone density by somewhere between about 2 and 8%. And it looks like the trials show that the resorptive activity is going to be reduced by more than 30% by 6 months. But unfortunately, the risk reduction of fracture occurs before the increase in the bone mineral density. So again, we have a question. Now you have to realize that the strength of the bone, as we've said many times, lies in the architecture of the bone and lies within the level of turnover of the bone. So we have high turnover bone. Well, that's going to be intrinsically unstable bone. That's part of the reason when we look at American women versus, say, Japanese women, the Japanese women, by all rights, ought to have a greater incidence of hip fractures because they're smaller, they have less bone mineral density. On the other hand, their bones are less unstable. There's less turnover of the bone. And as a result of less turnover, they tend to have less fracture. So that's a very important issue. So the rate of bone turnover is extraordinarily important. And as a matter of fact, the preventive trials suggest that the anti-resorptive drugs can decrease the rate of fracture in osteoporotic bones by about 50%, and that's supposedly without even restoring the bone mineral density. So the changes in the bone mineral density can relate to a decrease in the fracture of the vertebrae, but the evidence is kind of weak, and especially it's weak for the hip. And you have to realize that even with treatment, even when the women are at less risk, they're still in the osteoporotic category. So the question is, even if we can restore some of the bone density, what are we doing? And then there's another question, and that has to do with identification. So if we look at a fall in the bone mineral density that occurs with age, it may well contribute relatively little to the fracture risk. So they did a study. And they looked at about 6,000 women who were over age 55, and they found that if you look at women who were 80 years old, those women who were 80 years old had about a 13-fold increase in their risk of developing fracture. But if we were looking at the bone density, that would only account for about a 2-fold increase. So there's something considerably more important than bone mineral density. And as a matter of fact, even at the same bone mineral density in a woman age 60 and a woman age 80, the woman at age 80 is at considerably greater risk. So we think that probably about 85% of all of the risk of fracturing in older women has to do with their aging. It doesn't have to do with the bone mineral density. So finding out what the bone mineral density is adds relatively little. And then we have the relation between the bone density and the fracture risk. It seems to be age sensitive, and that T-score used to infer the risk of fracture, well, it's based on a concept of a fracture threshold. But we've already said that when we look at people, the majority of people who have fractures don't fall into that particular category. And remember, we're talking about young adults. Those are the norms, not older individuals. So it would appear just without question that age is a much more important factor compared simply to your bone density. So do you really need a bone density scan? Nah. So even in women who have the same bone mineral density, by the way, the likelihood of fractures, well, they vary significantly, vary by several fold. So we also know that the prevalence of fractures can be demonstrably decreased within just a couple months, supposedly, of taking the drugs, taking these anti-resorptive drugs. So there's another issue. Since most of the fractures occur in older people, why would we even consider starting younger people on medication when the medication isn't going to necessarily do anything to a woman who's age 50 or a woman who's age 55 or a woman who's age 60? Why don't we preserve them for women if we said that the overwhelming majority of women who develop hip fractures, 75% of all the hip fractures occur in people who are over age 75. The average age in the United States is about age 80. So why don't we consider just treating those women? And as a matter of fact, if we go to some of the other countries, in Britain, for instance, it's considered uneconomic, not considered a good idea, because if you look at women who are in the lowest quartile, so if you divide women by bone mineral density, the highest, mid, and low, well, you would think that women in the low risk, those are the ones who would have the greatest number of osteoporotic fractures, but that's not the way it is at all. And as a matter of fact, if we look at the groups, if we look at 8,000 women, we find that about 65 of those women are going to develop a fracture in any given period of time, in a year. And we're going to find that if we look at the women who are in the bottom quarter, well, only about 32, 33 of the women with hip fractures is going to fall into that group. And as a matter of fact, if we treat those women, we treat all the women because we have to treat the women, supposedly. If we treat them, we're only going to be able to reduce the number of hip fractures in a year by about 17 out of 8,000 women who are going to get treatment. And that's in a group of self-referred women. That wasn't a random selection. And we know that the bone density, at least according to our tests, is going to vary at different rates throughout the course of time. And we know that even though there supposedly is a correlation between one site and another, that's not an absolute correlation, because remember we said that you could have osteoporosis with a T-score falling into the osteoporotic range of just one bone site. So it might not be all your bones. Now, next thing that we have to worry about is that the bone turnover, not the bone mineral density, seems to be the responsive element. So it's the bone turnover, not the bone mineral density, not the number that you get from the test, that's important. But it's actually what's happening as far as the bone breakdown is concerned. What we were talking about a moment ago with the Chinese women, with Japanese women. So according to the National Osteoporosis Foundation here in the United States, we should probably consider treating women who are postmenopausal if they have at least one risk factor in addition to the age and to the sex and to the estrogen deficiency. And maybe, according to them, it might be appropriate to consider treatment or consider measuring the bone mineral density, rather, in all women who were at least over age 65, and now we've gotten it down to about age 50. So some people with cooler heads say, look, what we should do is let's use this FRAK test and let's look at the 10-year risk of hip fracture, and if it's more than 3% by our studies, let's consider doing something. Let's consider beginning some sort of therapy. So what they did in one study is they looked at women. They looked at about 700 women who were at this 3% threshold, and they treated the women for a year, and they had to treat the almost 700 women for a year in order to prevent one fracture. Now, unfortunately, the drug therapy that we have is relatively expensive, so when you average it out, in order to prevent one fracture, the costs are going to be, to prevent a fracture, somewhere between $48,000 and about $5 million, depending on which medicines, whether it's a generic medicine or whether it's an anabolic medicine. But the cost to treat one hip fracture supposedly is about $25,000 compared to the exorbitant amount that it would cost to get all of these women on therapy. So there's a question about what we do. Now, it's also very important to realize that the World Health Organization says it's probably not effective to go and screen women who are less than 65 years of age. National Osteoporosis Foundation, they're sort of in some agreement, but now we have a bunch of other studies, this FRAK study and some others, that suggest, well, maybe we ought to go and consider expanding our horizons, get more people tested and on therapy. But unfortunately, there's no information with respect to the FRAK's test of what's important as far as diagnosis and treatment. Do we really do anything good? Well, unfortunately, the studies are basically unreliable if they have fewer than 100 events, fewer than 100 fractures in the study. Then we can't really say much about it. On the other hand, 7 of the 11 studies that were used to get the FRAKs had fewer than 100 events. So it's done on unreliable grounds. So there's a lot of controversy. That's basically what we're talking about. According to the Food and Drug Administration, well, we should consider the bone mineral density testing in women who are estrogen deficient and at risk of osteoporosis, clinically at risk, people who have vertebral abnormalities or x-rays suggestive that they might have osteoporosis, women or men who are taking cortisone, prednisone, at a dose of more than 7.5 milligrams a day for at least 3 months, and people who have elevated levels of parathyroid hormone. And we ought to consider monitoring people who are on therapy, but we ought to monitor them unless there's a real good reason for it, with at least 2 years separation between the tests, because the tests aren't very accurate and they don't change very quickly. In men, we can study men in addition to women. Men, certainly if they've had a hip fracture or vertebral fracture, they would be subject, or if their bone mineral density is less than 2.5 standard deviations, well, we ought to go and consider treating them. Or if they have specific other kind of issues, then we should consider treating them. Now, according to the American Association of Clinical Endocrinologists, we should probably treat all women who are postmenopausal who have less than a 2.5 standard deviation change. And maybe if a person's had a fracture, ought to consider treating them. The National Osteoporosis Foundation takes a view that consider the clinical circumstances, consider whether they've had a previous fracture, whether the person's a smoker, whether the person's very thin, whether the person has a family history, and then use some of these other tests, but they have sort of a more liberal view as far as treatment is concerned. Now, the hip is a very important area to monitor, and we know that changes occur, and the changes occur relatively slowly. And if we look at the bone mineral density, in order for it to be meaningful, a meaningful change, it has to change at least in the hip by about 6% and in the vertebrae by about 4%. And that's going to take time. That's why we don't do the bone mineral density test every year or every 6 months. You wait at least 2 years. And as a matter of fact, there are a lot of people who are going to be outside the realm of what the tests can deliver. So even though the people are getting better, the tests might show no significant change. Well, if you do a test and you find no significant change, does that mean you should change the therapy? Nah. If you get worse, you might want to change the therapy, but if you stay in the same, that's okay. Now, what we have to do is we have to look, let's talk about this FRAK test again. National Osteoporosis Foundation supports it. It's funded, as we said, by Big Pharma. And according to this test, according to the FRAK test, that's simply done on a computer, well, overwhelming majority of people need to be treated. So if we look at people who are 65 years of age or older, according to the FRAK test, remember funded by the drug industry, at least in part, Well, the FRAK test comes up with the idea that about 70 some odd % of people need to be treated. And if we look at people who are more than 75 years old, then according to them, well, probably somewhere well in excess of 90% of the people need to be treated. Well, those numbers are at least twofold greater than the bone mineral density testing suggestions. So with this idea about FRAKs that is being done extremely commonly, we're getting more and more people being treated for a condition that they might not need any treatment for. And as a matter of fact, the original FRAK test would identify people who had a 20% risk of fracture or more than a 3% risk of hip fracture. Those numbers are basically cut in half. And now we have some other issues where some of the people who are behind the FRAK test are editors of a journal, a major journal in osteoporosis, and there's a question about conflict of interest, and we won't get into that other than to say that there's significant questions about whether a lot of the medical articles that are being published are gaining favorable access to a journal and whether some of the critical studies are not gaining access to the journal. Those are suggestions, not my suggestions, but suggestions of other people who are expert in the area. Now, if you want to know about the FRAK test, all you have to do is go into Google and type in FRAK, and you will be able to see how you can measure your particular risk of osteoporosis. Well, support for the FRAKs is by the International Osteoporosis Foundation, National Osteoporosis Foundation. It's supported by the International Society of Clinical Densitometry and the Association for Bone and Mineral Research. And you have to say, wonder if it's really helpful, whether it really is important that we expand the number of people who are being treated. Unfortunately, the information used to come up with the algorithms that they use in the FRAKs, not publicized, at least at the present time, no independent review. Well, what's the FRAKs based on? It's based on age and sex and race or ethnicity. It's based on your body mass index and history of fracture, parental history of fracture. It's based on whether or not you use steroids, whether you have rheumatoid arthritis, and it's based on the femoral neck bone mineral density from a DEXA scan. But if you don't have that, you could use your body weight. Now, there are some other methods of determining your risk. One of them is known as the Q fracture. This is done in the United Kingdom, in England, and you can look that up too. Just type in Q fracture on Google, and that will take you to the area of concern, and you can learn about this. And they use probably somewhat similar items, but they probably have actually better results than the FRAKs. They look at ethnicity, previous fracture, they look at antidepressant treatment, they look at whether you have chronic obstructive lung disease or epilepsy or Parkinson's disease, whether you've had cancer or whether you have type 2 diabetes, whether you live in a nursing home. And there's another one, it's known as the Garvan, and the Garvan, G-A-R-V-A-N, again, look it up on the internet, is out of Australia. They only look at 5 variables. They look at the age, the sex, the likelihood of a previous fracture over age 50. They look at your bone mineral density, and they look at the number of falls you've had in the past year. And from that, they decide what your risk is. Well, it looks like the evidence, at least at the present time, suggests that people, as they grow older, are at greater risk, and that means that a lot of people are being treated for osteoporosis with a variety of drugs. Now, the question is, do these drugs provide the kind of benefit that the general public expects? Are they really wonder drugs? If you take the drugs that are used for osteoporosis, are they likely to reduce your incidence of fracture, reduce the risk of fracture? And are they going to do it safely? And in what age should you begin therapy? Well, all of those are issues that we'll take up on our next show. Thank you for watching. I'm Dr. Ken Landau.